This conference will now be recorded.
Okay, now ఏంటది చేశాను. Now we are starting our class hepatic abscess. Okay, so we'll talk about the brief anatomy of liver. Grossly liver is divided into left lobe and right lobe, but this is not the anatomical classification. It is just a simple classification. The ligaments attaching, the importance of the inferior vena cava, gallbladder, and everything. So in the lower border, the porta hepatis enters just behind the ligamentum teres. Okay, so we'll talk about hepatic abscess only. So the segmental anatomy of the liver is Coinard classification. Actually, the classification of this thing itself will take one day. It is so vast, so I'll not go into deeply into it. So the division of liver Coinard basis is Coinard segments is based on 3 Cantley lines. The name itself is Cantley. Okay, so I'll show you the lines. So 1 line, 2 line, 3 lines. So 3 Cantley lines. Okay, so these 3 Cantley lines divided into 8 parts. Total 8. Segment 9 is segment 1 is separate. Okay, other 3 parts have directly drain into the hepatic veins, directly drain into IVC, but this only segment 1 will not join the right or left. It will directly drain into the IVC through hepatic veins. So the segmental anatomy of the liver is divided basing upon 1 portal vein, 2 hepatic vein. So this is how it is divided. So this is segmental anatomy. 1, 2, 3, 4, 5, 6, 7, 8. Total of 8 lobes, and they are named in clockwise direction. 1, see, you can see this here. So this is 1. This becomes 2, 3, 4, 5, 6, 7, 8. Okay. So the left lateral is 2 and 3. Left medial is 4. Right medial is 5 and 8. Right lateral is 5. Right medial is 5 and 8. Right lateral is 5 and 7. So the names and these things are quite extensive. This is actually an examination question, so you read out this thing. So liver abscess, it is a relatively rare manifestation, but high mortality. So this is in context with the developed nations, not at all with us, which is even hepatic abscess, though it is even reducing in intensity and incidence day by day, it is still even a major very surgical common problem in India even today. So despite advancements in medicine, incidence is relatively same for long time. It is almost 8 to 16 per 1 lakh. So the reasons we will see about later. Okay, previously used to be prevalent in younger age groups. Now it is disease of old age population. The reason being, previously it used to be more because of amoebiasis. That is why it is in the more of the young age group. But now it is more associated with malignancies or stone diseases or obstruction. So this is seen more in the older age group population. So briefly we will talk about this. Amoebic liver abscess, pyogenic liver abscess, and fungal abscess. For exam point of view, amoebic and pyogenic are very important, or even in clinical point of view. Fungal is extremely rare. I have never seen one. So amoebic liver abscess, the Entamoeba histolytica, most common extra-intestinal manifestation of invasive amoebiasis. Most common is colitis. Second is amoebic liver abscess. So etiology is Entamoeba histolytica, invasive form is there. Life cycle, first you ingest the trophozoite, which attaches to the intestinal wall. From there it will enter the portal vein, there hepatic parenchyma, there it divides and forms the hepatic abscess. So incidence is more common in the underdeveloped areas only. Most common in the developing and underdeveloped world. High risk groups including which is high homosexual men, immigrants, tourists to the endemic areas. This is very important. Tourists to endemic areas, immunocompromised, low sanitary conditions, low socio-economic status. So these are very important. Okay, so these are the important things. So it is bimodal age distribution. It's really not important. Most common in males. Reasons are unknown, but it is said that menstruating women are at protection. So any menstruating woman itself is a protective factor for amoebic liver abscess, but the reason is unknown. Okay. So pathology is fecal-oral transmission. 90% infected with Entamoeba histolytica are asymptomatic colonized. So how does it present? Means like the person could have had amoebic colitis long time back, but after few weeks or few weeks, not months, they may present with amoebic liver abscess. So even though you do endoscopy or something, you might not find any ulcers or anything. Okay. Life cycle, as again said, first it is cyst. On ingestion, it becomes trophozoite, then intestinal wall, invades the colonic mucosa, then through portal vein enters the hepatic parenchyma. There it forms the abscess. So trophozoites invade and induce apoptosis in colonic mucosa, resulting in buttonhole ulcers with undermined edges. So then trophozoites are actually found in the edge of the ulcers. So in the center there is nothing, necrotic material. So it is only seen in the edge. So by the enzymatic cellular hydrolysis, it will breach the mucosa and submucosa. Most common extraintestinal manifestation is in the liver abscess, occurring in up to 50% of adults. Majority are the males. Okay, here see. While in children it is less, but once it is there, invasive disease, it causes liver abscess in many adults. Okay. So the first focal necrosis is formed. Multiple microabscesses coalesce to form a single large abscess. Majority of the times it is a single abscess, but sometimes there can be multifocal. Majority of the times it is on the right side. Majority on the right side only. The reason being the laminar flow of the portal blood flow. As you see, so the portal vein like goes more tilting towards the right and acute turn on the left side. So this is the way it will be. So blood flow will be more towards the right side. You see the right lobe of the liver has more volume also. You can see that thing in the images. So it is more common in the right side of the liver rather than on the left side of the liver. Okay. Central cavity of the lesion contains homogeneous thick liquid, typically red anchovy. It is called anchovy sauce or anchovy paste in consistency. It is odorless unless infected. Please remember this thing. It is odorless unless infected. And again here also trophozoites lie in the periphery of the abscess cavity. In the periphery they start eating the liver bit by bit. So in the center nothing will be there. Center whatever it is there, it is only a dead material. So 75 to 80% single abscess located in the right lobe due to laminar flow, 6% in the caudate lobe, 10% in the left lobe, and rest are multiple. Only 40% have typical features of amoebic liver abscess. Serial scanning show no change in ultrasonic feature despite adequate treatment. Okay, you remember this. So sometimes if it is a 65-year-old, 70-year-old male, it is a very difficult thing to diagnose. You are doubtful whether it is especially when they are small. You don't know whether it is an amoebic liver abscess or a HCC. It is a differential diagnosis for HCC also. So the mean time for resolution is up to 7 months. It can take 7 months, and 70% it persists more than 7 months. Okay, eventually result up to 9 months you have to wait to find any resolution. Up to 9 months. So even after resolution, it resembles a simple cyst of liver. So clinical presentation, majority of the patient presents with pain, fever, weight loss, nausea, vomiting. Diarrhea is less, cough, pleurisy, weight loss. Okay. So usual case of amoebic liver abscess doesn't present with concurrent colitis, as I said before. Patient have had dysentery within the last year. Some time back, they might have some dysentery. So now after a few weeks to few months, they'll present with the episode. Or if there is any colonization of the amoeba, it will be even for a few months also. At some point of time, they will develop amoebic liver abscess. So synchronous hepatic abscess is found in 1/3 of patients with active amoebic colitis. So this is a again important point. Alcohol abuse is very common in these people. Remember, alcohol. See the main function of the liver is detoxification. Okay, and it is also a filter. bacteria. See, your portal vein circulation has lot of bacterial load and other things. So it is a filter for bacteria, and it is a filter for toxins like ammonia, etc., etc., along with nutrients. But it is, of course, liver is not developed to eradicate trophozoites or parasites. So they get lodged in that part and they develop abscess. So right upper quadrant tenderness, hepatomegaly, pain, pleural effusion, ascites, jaundice, etc. Jaundice is seen only in one condition, when there is obstruction of biliary tract. It can happen, but it is very rare. So patients presenting with acute and with chronic presentation differ clinically. Acute presentation is simply pain, fever, hepatomegaly, etc. But chronically, majority of the time they will have only dull aching pain. Other than that, nothing will be there. Fever, chills, tenderness, these are in acute. So more complicated course tends to ensure the in acute presentation, but response is seen similar in both groups. So symptoms, most common symptom is pain only. Pain 92%. Next is fever, pain and fever. Then come tenderness. So in that order, pain, fever, tenderness. So other things are there which are really not that important. So majority of them, prothrombin time is raised. That is the most important thing of prothrombin time. Here it is not there. So okay, it is not given. So okay. Prothrombin time is elevated in a case of amoebic liver abscess. That is the most characteristic feature of amoebic liver abscess, not alkaline phosphatase. Alkaline phosphatase is raised in uh, bacterial pathology, pyogenic liver abscess. But in amoebic liver abscess, it is prothrombin time. It is an exam question for you people. I mean, so these are the symptomatology and everything. So lab evaluation, mild to moderate elevation of counts. Sometimes even if it is a superadded infection, then counts are significantly raised. Alkaline phosphatase is increased. Jaundice is rare, but this is not the characteristic feature. Alkaline phosphatase raised is not the characteristic feature. Elevated prothrombin time is very characteristic of amoebic liver abscess. Okay, liver abscess is associated with positive stool samples in only 50%, 40 to 50%, not many. So radiology, the best investigation is CT, most commonly done, but the most commonly done is ultrasound of abdomen. Chest X-rays is also taken to see any pleural effusion, elevation of hemidiaphragm, etc., etc., or any subdiaphragmatic collection, etc., etc. MRI, everything is done, but they are non-specific. Ultrasound is the most commonly used for two reasons: one, diagnosis; two, therapeutic. You can even do an ultrasound guided pigtail, ultrasound guided fine needle aspiration, anything you can do. So diagnosis is definitely by detection of trophozoites, but majority of the times you won't get any trophozoites. But the other way of diagnosing is, see, either you will have an amoebic liver abscess or pyogenic liver abscess. This is the most common things, right? So amoebic liver abscess is, as I said, anchovy pus, red color it will be there. But pyogenic liver abscess, it is frank pus. So that is how you differentiate, just by aspiration, whether it is amoebic or pyogenic. So diagnosis, na, ELISA. ELISA is one of the most important diagnostic mechanism. Serologies, amoebic serologies. Amoebic serologies. This is also done. ELISA is the most sensitive test for that. So biopsies of an ulcer in the colon, if it is there, is also important. But usually we don't do any of these things. We just treat considering it amoebic liver abscess, because whether it is diagnosed as an amoebic liver abscess or not, the treatment will be the same: metronidazole and other anti-luminal anti-amoebicides. So we really don't diagnose all these things. If we see anchovy sauce color, it is treated as amoebic liver abscess. That's it. So serology, one indirect hemogglutinating test has sensitivity of 90%, but this is replaced. Enzyme linked immunoassays, ELISA. Now this is the most commonly done one, high sensitivity and high specificity. So this is the diagnostic imaging, sorry, diagnostic test. So this is again an exam question. They'll definitely ask you. So treatment, two things to be treated. One, active abscess. Two, the colonization of colon with amoeba. So to treat them both, first you need to treat the infection in the liver and then luminal clearance of amoeba. So metronidazole double dose 800 mg TID for 14 days is given for liver abscess, and luminal amoebicides are there. I have written, I think. So the diloxanide, paramomycin. Diloxanide is not used. Here I have written diloxanide furoate, paramomycin. Diloxanide furoate is not used commonly because of cardiac effects. Diloxanide has some cardiac effects, non-desirable cardiac effects, so it is not used frequently. So by doing the luminal clearance, the risk of recurrence is also reduced. Okay. So metronidazole 800 mg TID for next 14 days. 10 it is not correct. 14 days will be given. Okay. At 5 days, 85% cure is achieved and response increases by 95% by 10 days. Approximately 15% are resistant to metronidazole. The reasons are multiple. One, deep maybe vasopressin infection is there, or drug penetration is not effectively in the there, etc., etc. So, and one more drug, emetin. Emetin also has cardiac effects. Emetin is also known to have cardiac effects. Out of these two, emetin and diloxanate furoate, emetin is almost all out of market. It is out of market completely for the risk of cardiac effects. Okay, this is something you need to remember. So therapeutic aspiration. When do you aspirate a case of amoebic liver abscess? One, if it is present in left lobe. Two, if it is more than 5 centimeters in diameter in any way. Three, if it is likely to rupture, then also we will do. The reason being that the left lobe abscess and size more than 5 are more likely to rupture. That is why we will not wait. We will directly aspirate. Once it ruptures, most common site of rupture is peritoneal cavity. Unnecessarily, it will cause peritonitis and other these kind of complications. So to avoid that, we will do that. So again, if you want to aspirate, first medical management, and even after medical management, if there is no improvement after 7 days, then again you have to aspirate. Okay. So there are contraindications for aspiration also. One very common knowledge, liver dysfunction or deranged INR, you can't do. One. Second, if it is a very superficial or subscapular abscess, you cannot do any aspiration, because the moment you puncture, it will perforate and it will enter the peritoneal cavity. So in such cases, you don't have to do, you have to do operation. Okay, and especially in cases which are very close to the portal triad. So radiologist will not do. They have to do either CT guided or ultrasound guided. Usually they will not do. They are very scared. They will not do. Will not take the risk. They will ask us to operate. Okay. So Cochrane review in 2009 found percutaneous needle aspiration did not help patients with uncomplicated amoebic liver abscess. It's okay. This is one of the studies, that's all. Bacterial co-infection of amoebic liver abscess has been observed. Therefore, addition of antibiotics is also be necessary in some cases. Okay. So drainage, percutaneous drainage is best. Next, stenting. Direct stenting is also there. Most percutaneous drainage is most useful in treating pulmonary, peritoneal, and pericardial complications. Large diameter catheter is adequate for drainage, but this may cause some discomfort. Pigtail catheters, that is what they say. 10 to 14 French they'll use. 10 to 14 French. Okay, so it will drain, and then after that we can remove. Aspiration is abscess aspiration is a risk factor for secondary bacterial infection. Secondary bacterial infection rates, but now are a bit less. Okay. Surgical drainage, as I said, non-response to medical treatment. If it has perforated, hemorrhage into the cavity, peritonitis. If it is eroded into the neighboring structure, this is secondary to infection. Okay. The most common site of rupture of the peritoneal is into the peritoneal cavity. One. Okay. So much of area. Second, into the pleural cavity, and it can even go into the directly. It can come into the skin, chest wall. It can even go into the pericardial sac. Also, it can go. Okay. So these are the paths how it can extend. A rupture into adjacent organs has very high mortality because it causes peritonitis. That is the reason. Less commonly secondary to necrotizing or perforated amoebic colitis. The liver abscess usually attaches to the diaphragm and the anterior abdominal wall, or the omentum and bowel tend to wall it off. That is the nature of the omentum. That is the function of the omentum. It is called the abdominal policeman of the abdomen. Okay. Usually, free rupture into the peritoneal cavity is uncommon. Occurs in moribund patients. I have only seen till now one case. It is very much morbid. Once it is ruptured, it is very much dramatic. It has dramatic effect on the patient general condition. They will deteriorate very fast. So again, thoracic perforation, thoracic has also happened. So once thoracic happens, if it is in the restricted only into the pleural cavity, na, easiest treatment is ICD, because once you place an ICD, all the pus will come out. Or if it opens into a bronchus, there is nothing you need to do. You need to just use dilators, bronchodilators. The bronchodilators themselves will dilate the tree, and the pus will come out of by coughing. And postural drainage, here I have written. Just by postural drainage, bronchodilators and anti-amoebic drugs. That's all. Okay. Left lobe abscess more common in pericardium. Pericardium tamponade also requires aspiration. It is called pericardiocentesis. And if it is in the pleural cavity, thoracocentesis. Okay. Cerebral amoebiasis is seen in very less form, but it is very seen in severely ill and may experience seizures also because of the edema. There will be a lot of cerebral edema because of the infection. It is very seen in very much immunocompromised patients. Very rare. I've never seen one. So outcome usually the person, if it comes early treatment, this is very good. But there are few risk factors are there. Hypoalbuminemia, serum bilirubin more than 3.5, encephalopathy, abscess volume more than 500, presence of multiple cavities, etc. These are actually risk factors. They predict the morbidity. Okay, mortality and morbidity both. These things keeps on increasing. Okay. So again, coming next to the pyogenic liver abscess. Nowadays, amoebic liver abscess is coming down and pyogenic liver abscess is going up very fast. Okay, the reasons are multiple. One, you have good access to anti-amoebicidal, metronidazole. Till now, metronidazole, as far as I know, there is no resistance in anaerobic organisms for metronidazole. Okay, and parasites like amoebiasis and everything. It is very rare, very less common also. But biliary tree diseases are increasing, like CBD stones, etc., etc. Now this is one of, and malignancies, periampullary malignancies. Now this is one of the most common reasons for any person to develop pyogenic liver abscess: immunocompromised state, ductal stones, or obstruction. Okay. The first description is in the year 4000 BC. They don't know what the disease is, but they have described the features. Okay. Again, this is also laminar flow up to 75% in right lobe. This is also same. Here the male and female ratio is a bit same, almost same, 1.5:1. About 50% are solitary. Okay, same. It is almost parallels with the amoebic liver abscess. Only the causative organisms are different. Okay, so the biliary tree organisms are the ones which causes this disease. They are Enterobacteriaceae family. Majority are from the ascending suppurative cholangitis. Biliary enteric anastomosis malignancy. Okay, previously appendicitis used to be the most common reason, or diverticulitis. Now both are gone because of early diagnosis, antibiotics. Completely portal pilophlebitis is completely gone. Now these are remote causes for amoebic liver abscess, sorry, pyogenic liver abscess. Okay, some septicemia patients can develop due to direct extension from artery, gangrenous cholecystitis, subphrenic abscess, perforated ulcers, penetrating trauma, etc. These are all very rare. The Kupffer cells acts as a filter. Liver has function of both clearing the pathogens, clearing the toxic materials. Okay, when normal hepatic mechanism, clearing mechanism is failed or overwhelmed, then abscess develops. So biliary is the most common, up to 40% of the liver abscesses, then malignancy, etc. Obstruction of the biliary tree is the norm, and then cholangitis is seen, also seen. Intrahepatic stones are predominant in the eastern cities. Eastern in the sense like Malaysia, Singapore, Thailand, these countries. We don't come into that place. Okay, but compared to the West, this picture is very common for us. CBD stones are the most common cause for cholangitis in India also. Any therapeutic or endoscopic procedures done, okay, stenting, drainage, etc., enteric anastomosis, malignancies. See, this is the most common reason nowadays, increasing nowadays, not most common, because malignancy, poor nutrition, immunosuppression, and so everything is exaggerated now. Okay, so appendicitis now, as I said before, only 2% nowadays. That too also neglected long term. That is how it happens. Then diverticulitis, perforated colonic cancers, etc., can also cause trauma. Radio frequency ablative procedures. Remember this thing. Okay, radio frequency ablation is done for hepatocellular carcinoma. These cancers, no? Necrosis happens, and then they can spread and they can form pyogenic liver abscess. Trauma. Which kind of trauma? It is only penetrating liver injury, which is very uncommon, which is also not known, not seen at all commonly. So cryptogenic, the name itself is suggesting cryptogenic, unknown causes. We cannot identify definitely to one source. Okay. Usually they have comorbidities. Diabetes is the most common culprit. Diabetes itself will cause immunosuppression. Okay. Abscess tend to be solitary and usually contain a single anaerobe if it is a cryptogenic abscess. Okay. So if it is a biliary one, usually that is also anaerobic one, enteric bacteria will be there. But if it is a septicemia induced liver abscess, usually there will be multiple, because hepatic artery is supplying, multiple lobes are involved. Okay. So this is the incidence, approximately 15 per 1 lakh admissions today. Rising incidence is more aggressive management with hepatobiliary pancreas and advancements in diagnostic imaging. Okay, so this is something. So predisposing factors, again, nothing much. Again, I have also told them. Older patients are likely to have here. Older patients are more likely to have a biliary etiology or underlying malignancy. Younger patients are alcoholic males and cryptogenic origin. So the case fatality, the death in are mostly depend upon the general condition of the patient. More immunocompromised, more age, more the mortality. Okay, here age and Apache are given. Apache score, high Apache score is again a risk factor. So underlying malignancy is a risk factor. Young, very young or very old. Very young it doesn't occur usually. If it is happening in young, you have to look for these things: immune disorders or chronic granulomatous disorders, or complement deficiencies, leukemias, malignancies. You have to get that thing. If a child is frequently getting affected by any viral fever or bacterial fever, mainly bacterial rather than viral, chronic granulomatous diseases, immune disorders, nutritional disorders, malignancies, complement deficiencies, it is the most common reason. Okay. Hepatic abscess are also seen in sickle cell anemia, congenital hepatic fibrosis, polycystic liver disease, and liver transplant. Liver transplant patients, thing with these liver transplant patients, they already are immunosuppression. That is the reason why they develop it. And number here, sickle cell disease I have written. Any sickle cell, any hemoglobinopathy, they are more prone for liver abscess and spleen abscess. That is the rule. So these are the reasons. Chronic granulomatous disease, very common in young fellows, children. This is how it is. And if it is an adult, it is diabetes. Okay. So majority right, source can be predicted by, as I said, source can be predicted by number, size, and location. If it is a biliary pathology, usually it is a single large one. If it is a portal, a traumatic, cryptogenic, usually solitary, large, while biliary and arterial abscess are multiple and small. Sorry, biliary is multiple. Okay, biliary and arterial are multiple and large. Fungal is also usually multiple, bilateral, and miliary. Miliary, and I think you people know what miliary means. Miliary means multiple dot like. Okay. So solitary abscesses are usually polymicrobial, anaerobes majority of the time. Diagnosis is confirmed by culture. That's it. It has to be cultured. It has to be sent. Most commonly Klebsiella in India, E. coli worldwide. E. coli more in the Eastern world. Klebsiella in India. Klebsiella in India and diabetics. It is frequently associated with gas-forming abscess. Klebsiella. Other things are also there. Bacteroids, Fusobacterium, etc., etc. Okay. See, most common is E. coli. Okay. Cancer patients who is undergoing immunotherapy. See, if any person develops a systemic fungal infection, it means he's immunosuppressed. That's it. There is no other way. So some kind of things are there, either HIV, chemotherapy, or some disease, something is also there. Mycobacterium tuberculosis is common infecting organisms in AIDS. This is everyone knows. This is nothing much. E. coli and Klebsiella will come from biliary tree. E. coli anaerobes from the intestinal tract. Diabetic is a risk factor for Klebsiella pneumonia, liver abscess, and significant risk for embolic complications. So diabetic having Klebsiella pneumonia, they have a specific but uncommon complication, endophthalmitis. They may lose their vision. It happens in up to 3% of the people. Even though it is very uncommon, you have to keep an eye. Okay. Diagnosis is always aspiration and culture. So classical triad of pain, fever, and right upper quadrant pain and jaundice. This is seen in less than 10% of population. Okay. Majority is pain, fever, jaundice. Others are chills, diarrhea, etc. Most commonly constitutional symptoms are then diaphragmatic involvement causes pleuritic chest pain, rupture most commonly happens into the biliary tree, I think. Cause it can rupture into the peritoneum causing peritonitis, sepsis, etc. Unfortunately, classical triad is seen only in 10% of the people. Ascites, splenomegaly, and severe sepsis are uncommon. Okay. So again, I have said before, alkaline phosphatase is raised in 80% of cases. So just for a mnemonic to remember, see, as I said, amoebic liver abscess is very common in which condition? It is more common in alcoholics, while pyogenic liver abscess is more common in biliary pathology, correct? So alcoholics, what happened? Cirrhosis, liver function is deranged. So PT is elevated. PT is prothrombin time, that is elevated. But while the biliary pathology in some obstruction or stone is there, alkaline phosphatase is elevated. So that is the simplest way to remember. Okay. It doesn't mean that PT is not elevated in pyogenic liver abscess also, but just for you to remember, I am just giving a mnemonic kind of thing. So radiology, best is CT scan. Ultrasound is also good. MRI is also MRI rather than MRI. CT is superior than MRI for identifying the biliary tract pathology. So CT scan, CCT abdomen is the best investigation. Okay, so this is a plain X-ray film where you can see gas. What you see here is a gas. Gas forming organisms is there in the liver. Here also. So here you can see you are really doubtful what this one is. We don't know. Okay, usually pyogenic liver abscess have peripheral enlargement, which is not seen typically in this image, and it looks like a malignancy. If you see, someone cleanly observes, these are differential diagnosis for liver malignancies also. And what you see here is a peg tube. Ultrasound guided peg tube was placed, and that this is how exactly it looks like. Okay, this is how exactly it looks like on CT. So differential diagnosis is echinococcal cyst and amoebic liver abscess. Treatment is appropriate antibiotic drainage. Same, the indications and contraindications of amoebic liver abscess and pyogenic liver abscess are the same. Okay. So broad spectrum antibiotics are started, or if you suspect biliary pathology, you cover the E. coli or Klebsiella, this anaerobes, E. coli, the suspected thing you should start. Cultures were done. Blood culture should also be taken here. Okay. So blood culture are also always taken. Uh, So always add metronidazole, clindamycin, these kind of drugs. Metronidazole is the best. Metronidazole is cheapest and everything. It covers almost all anaerobes are susceptible to metronidazole. Next comes clindamycin. If metronidazole is not there, then clindamycin. Antibiotics, it should be very higher end antibiotics like cefoperazone, sulbactam, piperacillin, tazobactam. These kind of drugs should be used. So Klebsiella pneumonia is intrinsically resistant to ampicillin. Metronidazole is ineffective against aerobics. It is highly effective against anaerobic, but ineffective against aerobic. Remember, always remember this. Okay. So combination of aminoglycoside either with extended spectrum such as piperacillin or cephalosporins are used in Klebsiella pneumonia. If multiple liver abscesses are there, very small, less than 1.5, nothing can be done. Non-surgical drainage, you can drain using ultrasound guided drainage can be done. Fungal miliary, it is very small. They are not amenable for surgical drainage. What you have to do is only medical management. Okay, so candidal abscess are seen in disseminated candidiasis with severe hematological malignancies. Hematological malignancies on chemotherapy. CT means chemotherapy with neutropenia. So very severely immunocompromised people only develop candidial abscesses. Okay, usually associated with very high mortality rate. Drug is amphotericin B. The most common side effect of amphotericin B is hypokalemia. Potassium will go down. Okay, it is highly resistant for any treatment. The hypokalemia caused by amphotericin B is heavily resistant for all treatments. Okay. So needle aspiration with catheter drainage, needle aspiration, percutaneous drainage have similar mortality rates. Recurrent rates requirement may be greater in those undergoing aspiration alone. If you leave a catheter, what happens? You keep it for 10 days or 20 days, everything will come out. Sometimes what happens? Abscess is thick, it will not drain on aspiration, on first aspiration. But once you put a catheter, now after some time the coagulum necroses and it will slowly start coming out. That is why catheter drainage is superior. But needle aspiration has also its own advantages. Very simple, less invasive, less expensive, and patient will not have any discomfort. Okay. So if you only do aspiration, you have to do many times, not one, multiple times are needed to get effective success. So that is why in our places, majority of the times catheter drainage is preferred. So highest recurrence rate is seen in patients with biliary tree disease or obstructive lesions, whereas recurrence rate with cryptogenic abscess was less than 2%. Okay. So percutaneous drainage is not useful if pyogenic liver abscesses are multiple. If it is a cavity, it is divided in multiple multiloculated, that is exact word. Multiloculated, they don't usually drain good with catheter drainage. You have to do a surgical drainage, no other option. Okay. Any abscess that require transpleural drainage or ascites, abscess of unknown etiology, these are not actually advised. Any other intra-abdominal source require surgery, these are not advised. Surgical drainage less than 15%. Majority of the times it has perforated or not amenable for medical management. Thus kind of things you have to do surgical drainage. Transperitoneal is the laparoscopic transperitoneal is the method of choice. Any abscess greater than 10 centimeters should be initially treated surgically. Okay. So here it is, the algorithm is given. If it is less than 3 centimeters, single antibiotic therapy, percutaneous drainage. If not drainage, drainage if not responding for antibiotic treatment. But if it is more than 3, unilocular percutaneous drainage. Then if it is not working, then surgical. Multilocular direct, nothing. Percutaneous drainage plus or minus it is here. Even though it is mentioned percutaneous drainage is tried, usually it doesn't work really good. Surgical drainage, then percutaneous drainage is not responsive. Okay. So complications are seen in 40%. Sepsis is the most common complication. The general condition of the patients who is having pyogenic liver abscess is very bad usually. That is probably the reason why they end up in having sepsis very common. So Klebsiella pneumonia, bacteremia is 95%, so more prone for distant seeding, endophthalmitis, extrahepatic abscess, etc. So this is the thing. So factors predicting poor outcome like diabetes, malignancy, age, higher age, biliary pathology, multiple abscess, septicemia, polymicrobial, total count raised, albumin less, very less than 2, anaerobic abscess, significant complications, etc. So outcome, mortality even today, this is very high. Previously it used to be 70, very high. Now it is under 10%. Okay. So this is an exam question for you. What are the differences between amoebic liver abscess and pyogenic liver abscess? Age presentation is different. Amoebic liver abscess occurs young. Pyogenic abscess in more than 50. Male-female ratio is different. Both are solitary. Remember, amoebic and pyogenic, but amoebic is more commonly solitary. Pyogenic is slightly more commonly solitary. Location both in right liver. History of travel is seen in amoebic liver abscess. Diabetics is more common in pyogenic. Alcohol is more common in amoebic. Jaundice is more common in pyogenic. Okay. Elevated alkaline phosphatase is seen in both. Elevated alkaline phosphatase is seen in both, but elevated bilirubin is seen only in this pyogenic liver abscess. Positive serology in amoebic abscess, while positive blood culture is seen in pyogenic liver abscess. Okay, so these are the differences. So this is again an exam question for you. Again, in amoebic liver abscess, PT is characteristically increased. Pyogenic liver abscess, alkaline phosphatase is characteristically increased. Okay, so this is the class on today, pyogenic liver abscesses. So any doubts you can ask. If you want, I can clarify you. So if you don't have any doubts, we will end the class. So this is an exam question for you. These things, the division of lobes are also asked. This is a very extensive topic, very above. Usually it goes high above your head. You won't remember. So basic things you remember. That's all. That's all. This is the image that you need to remember. Total 8 lobes, but lobe 1 is different. 1, 2, 3, 4A, 4B, 5, 6, 7, 8. Okay. So cantilever lines division is based on portal vein and hepatic vein. Okay, and every segment is supplied by own portal triad. Branches of portal triad. So this is the thing. So every segment has a name also. Every 8 segments they have a name. So you just read it yourself. It can't be. It is just mugging up. That's all. You have to just mug up. Okay. So we'll end the class. Fine.
Yes,
We'll end
sir.
the class now. Okay. Thank you.